Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
These three presentations will be followed now by discussion questions from the audience. I would really encourage you to come to the mics, introduce yourself, direct the question to one of the three speakers. Also would like to encourage the speakers to ask each other and have a discussion here about the state of the art in oral oncology. In a couple of hours that we had here, we have seen the span all the way from basic mechanistic understanding of the disease to the diagnosis of the disease and then the surgical treatment. So there is a lot of ground to cover that was covered in these 2 hours. So let's have a discussion about these topics. And as you try to get courage and walk to the mic to make the first question, I'll get this thing started here. But please come to the mics and make yourselves known who you are and then ask questions too. So my first question is to Dr. Polverini. And that question is in regards to dormancy and UPR. So when you were presenting that data, I couldn't help myself but thinking about the angiogenic switch. And that is kind of a concept that is always behind our backs as people who do angiogenesis research. What turns it on, the angiogenic switch, and make a dormant disease wake up and become proliferative and grow and expand and cause problem. So is there a role for UPR perhaps in this process that regulates the angiogenic switch in avascular tumors?
Yeah, well, I think when you talk about the angiogenic switch, you really talk about several switches. The original description of it, the one we actually made back in '89, was the switch occurred when a tumor suppressor gene was turned on or off. When you turn the suppressor gene off, what happened, you switch from the dormant to an active state in which either mediators that had already accumulated were functioning and no longer had the inhibitors to sort of counterbalance them. So that was the first switch. There appear to be other additional switches by which this can work. And it may be, again, looking at the unfolded protein response, that more than the pathways may interact with each other to actually accomplish that same goal. So the really complex part is trying to find out how these how these pathways really function as networks. And so the networks expand, not between, even within a particular process, there may be multiple networks. So trying to connect those up may be, and help explain how the switch works in this setting. But what we're beginning to see is that there are multiple switches to trying to define it.
Mm-hmm. Very good. Dr. Macaulay.
Thank you, all three of you. It was excellent presentations. I have a couple questions that could be answered by perhaps a couple of you. But I was really taken in the beginning of your presentation, Dean Polverini, when you were looking at prostate cancer survival rates versus oral cancer. And I believe that the improvement in prostate cancer survival rates has been largely because of earlier diagnostics. And then that gets to Dr. Ward's kind of ending statement about early detection. So I'm curious if you think with the unfolded protein response, you convinced me that it could be a therapeutic target, but I'm curious if it could be a diagnostic. And along those lines, perhaps Dr. Sciubba, with his expertise in diagnostics, could comment on what requirements would we want to have in an effective diagnostic?
Well, let me talk about the potential for the unfolded protein response as an early diagnostic indicator. What I think we will see is that as we sort of dig a little bit deeper into the process, that there may be elements of that process that may come up or go down depending upon different. So it may be, there may be a pattern that emerges between several of these proteins that says, this pattern has emerged through a blood test, for example. It says, you know, this patient is at risk, perhaps, or this patient has taken one step in it. So I think pattern analysis of more than one of these may be very helpful.
I think in terms of diagnostics, we're a long way from serum diagnostics. It's very complex. People here and certainly at Johns Hopkins are doing this. But from the traditional histopathology standpoint, the diagnosis remains pretty much as it was. However, the art of the deal, as it were, speaking of Donald Trump without his hairpiece, would be as follows. What is to say that your moderate dysplasia today is your cancer tomorrow versus your next door neighbor who has moderate dysplasia today has nothing tomorrow? So what are those markers that we can begin to think about developing will enable us to say, you need treatment and you simply need to be observed. I think that's where the charm exists. Development of markers, and they're well underway, to help us not only predict, but more or less say with a degree of certainty that this is a bad actor and this is not, and then design appropriate therapies accordingly.
So what are the logistics of that? So if Dr. Polverini said to you, well, from the work that we've done, we think these could be markers. So then, tell us about the trajectory that goes forward for it to actually become a reality.
Yeah, to take it into the everyday laboratory, be it at a university setting or even at a commercial lab setting, it's just understanding the molecular biology of the process better and those particular networks and pathways which are specific to the transformational process. Mm-hmm. That's where it has to go.
Well, those are the first steps, and then I'm talking about all the way into somebody's hands in practice.
If I can make a quick comment, one of the difficult things to kind of get our minds around is the differences in some of these other cancers regarding prevalence compared to ours. So prostate cancer, by the time you're 80 years old, 50% of the population has prostate cancer. When you're 50, 20% of the population has it. There's no age group in oral cavity cancer that gets anywhere near that. Mm-hmm. So the ability of a diagnostic test for prostate cancer, PSA is worse than things that have even been brought potentially to the market for us. But they work because the population is such that the test is going to perform well. So a low sensitivity specificity in a disease with high prevalence is going to work pretty well.
Right.
That's the problem we face with oral cavity cancer. It's almost an orphan disease compared to prostate, mm-hmm. breast, and so mm-hmm. on. And
so just the numbers make it really difficult to move forward.
You really, if you crunch the numbers, we'd need a test that has 99% sensitivity and 99.5% specificity before we'd be looking at a false positive rate that would be something we really would want to all live with. We can get lower than that, but then you got to think about, what am I going to do with the false positives? Am I going to biopsy them all? Am I going to do endoscopy? What am I going to do when the test tells me they have cancer, but they don't?
I think also the steps have to be baby steps. We have to be willing to accept degrees of specificity and sensitivity, which are not maybe necessarily to our liking today, but are darn better than what it used to be 10 or 15 years ago before we devised some of these screening and or ancillary testings. So don't turn your mind off to it if it's not yet quite perfect.
Thank you.
So I would certainly stimulate students to ask questions too. Matt?
Oh, hi, thank you for coming and speaking.
This is called the anti-Socratic method. Matt's going to pimp me now.
You are my past student. I should say that.
You're on the block, Dr. Ward. So my question is basically for Dr. Ward and Dr. Sciubba. With regards to HPV being identified as a potential etiologic factor for oropharyngeal cancer and the different treatment modalities used in the treatment of HPV-related oropharyngeal cancer compared to non-HPV-related cancer, not only have we seen that we now have a potential etiologic cause, but we also have, or excuse me, not possible contributing factor, but we also have an increased incidence with those, that cancer subset. Should we be focusing on the prevention of the development of cancer in people who are known to be HPV, as opposed to focusing our efforts on treating people who have an HPV cancer? And I guess that brings up the question of vaccinations for people and where you stand on that, and if that's a reliable and reasonable treatment or preventative plan, or if we need to be thinking elsewhere.
Well, I'll start, Brent, if it's okay with you. Clearly,
Anytime you want to start before me.
I think you've got to do both. I think you've got to look at the preventional strategy, you've got to look at the therapeutic strategy. But one thing is clear, HPV-related cancers do much better than non-HPV-related cancers and the non-smoker, non-drinker. The issue of prevention strategies, of course, social change. Everyone is going to continue to have sex. I don't care how convincing you are about not to have certain kinds of sex. It's going to happen anyway. So how do you deal with that? You deal with it by encouraging your children to be immunized appropriately, both men and women, boys and girls, and educate parents as well. I think that's a start. There are therapeutic vaccines in clinical stage 3 trials right now, 2 and 3. And of course, the Gardasil does work for 16, 18. But remember, there are about 30 or 40 at least HPV strains which are oncogenic, but 16, 18 are the big ones, and at least we have one big step in the direction with Gardasil and its congeners. So I think steps are well underway, both from a societal standpoint, a behavioral standpoint, and a therapeutic standpoint for this particular subset of head and neck cancer.
I'll just add to that the jury's out. We don't know. Could help, probably won't hurt. And so I think from the prevention side, that's a reasonable approach to take at present. From a treatment side, I'm a little less enthusiastic, and I'll make this a little personal, but a brother-in-law who has oropharyngeal cancer, and the question being posed was, outside of a clinical trial, shall I be treated with de-escalation therapy or regular therapy outside of a clinical trial? And my recommendation for him was, I'd be treated with standard therapy. And until I know from a clinical trial that we can de-escalate, I'm certainly not ready to recommend de-escalation. But I strongly recommend patients enroll in clinical trials and help us understand that so that it can affect the treatment of the individuals that come behind them.
And make it clear also that the standard trials are quite effective.
So is there an opportunity to learn from HPV-mediated cancers? We know that in terms of response to treatment, we know that they respond better to treatment than non-HPV. But why is that? Any thoughts about why HPV-mediated tumors tend to respond better from any one of you?
Wish I knew. And I think the corollary is we think something's going on in oral cavity. I mentioned that, but we don't know what it is yet. And I think what can be learned from oropharyngeal is that this patient population that we're looking at, young females, non-smokers, who we were shrugging our shoulders at, now I think it is, hey, we know there really is something else going on here. We need to find it. And so if anything, the lesson is take that enthusiasm from having found something that made a difference at another site and infuse that enthusiasm into oral cavity. Let's find what it is in oral cavity that's doing the same thing.
I think Dr. Ward's point during his presentation was 1 inch away, this cancer is a different animal. Mm-hmm. And what are those differences? It's not simply differentiation. It's got it may not be epithelial even in origin. It may well be field. It may be stromal interactions, which is where a lot of this research emphasis is now being directed. Mm-hmm. So we've got to look at everything beyond just the epidermal growth factor receptors, tyrosine kinase inhibition, and so forth to help explain these particular variations in behavior.
Mm-hmm. Yes.
Hi, my name is Eric McCurley. I'm a first-year student. I have 2 questions.
Congratulations for the courage to stand up and ask a question. Thank you very much.
Thanks. I have 2 questions. First for Dr. Polverini, and then a separate one for Dr. Ward. My first question is, you talked a little bit about how the unfolded protein response is also a part of the normal cellular stress response. Can you just comment a little bit on possible adverse effects from targeting the UPR response in a cancer situation?
Well, anytime you attempt to monkey around with the normal physiologic process, you run the risk of really causing damage. The strategy we'd like to think of is if we begin to target within that pathway certain elements that we know are only going to be activated at certain stages, then we probably have a better chance of affecting a real change. But I think you bring up a good point. The whole problem with tumor therapy today is lack of specificity. So as we dig deeper into mechanism, define networks and pathways, the goal is to be able to be so precise in how we target that we affect a change only where we want it to be affected and when we want it to be affected. So it's really a lot to do about specificity. The other issue is that typically in cancer, you get many of these pathways are cycling so rapidly that you target those at a dose of an agent that is effective with those, but it's too low to affect a normal process. So it has to do with degree of activation, has to do with specificity. So that's the things that we think about anytime we're talking about targeted therapy.
Just one comment to that. I think medical oncologists and radiation oncologists, they can kill cancer. The problem is they got to kill cancer before they kill the patient. And so that's, we have treatments that kill cancer, but can they kill the cancer before they kill the patient? And that's what they're dealing with. And when Dr. Polverini says, sensitivity, that's what he's talking about, will the tumor be more sensitive to the drug than the human body will be? And if not, it may cure cancer in a dish, but when you put it in a human, you're not going to get into clinical application.
The buzzword is targeted therapies, isn't it? If you look at lymphomas in particular, where we have anti-CD20 monoclonal antibodies in the form of rituximab, that's the ideal sort of tumor you want to work with, certain forms of lymphoma, B-cell lymphomas, where it works like a charm in many instances. We don't have such a gun right now for oral cavity, oral head and neck cancer, but we will once we understand the biology of those cells a lot better as we do lymphocyte biology.
And then for Dr. Ward, you mentioned that probably on average in a general practice office we'll see a case like this once every 15 years. From your perspective as like an OMFS person, what's some of the practical ways, some of the best practical ways in your mind we can keep that information fresh so we don't miss those smaller cases?
That's a good question. And I think, knowledge of the disease and high index of suspicion, you got to look. And then when you find things that are abnormal, never, ever, ever be shy to refer that to somebody else who's seen this more than you have. And I think one of the problems that oral and maxillofacial surgeons have is turning around and saying, "You shouldn't have sent this to me. I didn't need to see this." Don't worry about that. Don't worry about someone saying that to you. If it looks abnormal to you and you're only going to see it once every 15 years, send it to somebody else. And if they have seen that a lot of times and it's nothing to worry about, great, you did your part.
If you're a clinician who has 10, 12, 15 years of experience, you're going to know something's not right. The charm for me is for you to act upon that. The issue becomes many times in my experience is that clinicians oftentimes don't act upon that. And they'll simply say, "I'll check it in 6 months," presuming the patient's going to come back in 6 months, presuming it can wait 6 months. If you see it and it's not according to your experience what it used to be, send it to people like Brent and I and many others. So use your frame of reference as your touchstone and move forward from there and refer appropriately.
Thank you.
Thank you. And if you're interested in oral surgery, please see me afterwards.
My name is Derek Finkovich. I'm also a D1. My question is not nearly as scientific, but it came to mind when you were talking, Dr. Ward, about different risk factors such as alcohol and tobacco products. Out of curiosity, alcohol-based mouthwashes, if you use them daily, do they pose a risk, an oral cancer risk?
I think Dr. Sciubba should go first again.
You are a whippersnapper sometimes. I'll tell you a personal story. Many years ago, maybe 1990 or so, I was asked to go to New York City and work with a group of people around this very question. The group and the study it wasn't even a study, it was really a series of opinions by individuals who were thought to know something about this very question. What about Listerine, et cetera, et cetera, et cetera? And the conclusion reached at that time was there were just too many confounders around whether or not Listerine and its other related partners can be said to be influential, because many of those folks who were using alcohol-containing mouthwashes were using it because they were smoking and drinking and wanted to hide the effects on their breath so their wife and her husband wouldn't know. However, there's an emerging body of knowledge based upon some Italian studies that alcohol itself may be a carcinogen. And if I'm going to put 26% alcohol in my mouth, I'm going to drink it.
There's another thing to remember when it comes like agents like alcohol, that many of these work systemically, so they have to be metabolized. So often, many times when you take an agent that's a carcinogen, the native material itself may not be carcinogenic, but once it's absorbed, it can actually, and it's metabolized, that's when you worry about agents becoming more or less carcinogenic.
And just to add a little levity, you know, I'm Mormon, I don't drink, but my mom used to use Listerine like crazy until I was in dental school and she had a leukoplakia and we said, stop using the Listerine, and it went away. So completely anecdotal, and I defer the answer to the question to what Dr. Sciubba shared with you, but that's why it's good to have Dr. Sciubba here.
I'm a non-Mormon Italian who likes wine just as well as my good friend, Dr. Hellman.
Yes. I had a thought about just what you were talking about. I think mouth rinse had come up some years ago. Viadent, I think was the name of it. The sanguinara root or something like that.
Sanguinaria.
Sanguinaria. And it just brought a thought to my mind. That's not my question, though. TVR advancing to verrucous cancer or to moving on to squamous cell carcinoma. 40%, 50% chance, maybe up to a 70% chance this goes on, but at an early stage when you don't see it at this point or clinically, what's the timeline where this can develop and how quick, and I know it varies, but in your experience clinically, number one question, how quickly does this develop? And then while the patient is not symptomatic or bearing any issues with it, how are you going to convince them that, look, we need to deal with this and we need to deal with it soon, or we can wait and it's going to be an issue otherwise?
I don't think there's any one answer to your question. There are trial attorneys who do medical malpractice and so on who'd love the answer to that question. Was it here, doctor, 8 months ago or 18 months ago or 15 months ago? No one really knows. And someone who sits up there in a box in a jury in a courtroom says, for sure this was here 12 months ago and Dr. Ward missed it. Well, maybe Dr. Sciubba didn't see it either 3 months ago. I don't know if there's an answer, but clearly oral cancer, a relatively slow-growing lesion, relatively underlined, takes many, many months to evolve until it's a clinically detectable lesion. And once it becomes clinically detectable, it still will take many months for this thing to progress at a rate that's alarming. It's still appreciating the abnormal and acting upon it. Growth rate not otherwise specified, because it'll be variable from one case to another, I am sure.
And I think that the experience that's been reported, Dr. Silverman's group, Dr. Began's group, I mean, this is something that tends to be slow-growing, you know, non-remitting, not amenable to therapies, and a progressive disease that continues despite what we do. We don't generally see it rapidly change before our eyes. So in regards to PVL, tends to be a slow progressing process. The reason it gains attention is because it's a slow progressing process that we can't seem to stop no matter what we do in regards to our normal surgical treatments, lasers, or surgery that are the general things that would be pulled out to try and treat a disease process. Similar, this one's somehow different because it doesn't respond to those at all.
And your pathology reports along the way, you're going to just continue to biopsy as you progress? Would you expect or would you recommend?
I don't know quite what you mean by your pathology reports along the way. Clearly,
well, I'm sorry, I should say, you'll go ahead and at the early stage, you'll want to biopsy, and your pathology report might be inconclusive. And that's not the end of the world, but you have to, or it might just be undefined leukoplakia, something sort of along those lines.
Well, clearly sampling is part of the issue. You have to sample appropriately to get a good answer to the process at hand. And acting upon that particular information that the pathologist is going to give you with routine testing modalities. If you get a report back that says dysplasia at one level or another, you're obligated to discuss it with the patient and arrive at some form of treatment conclusion. Now, most people don't treat mild dysplasia. Some people treat moderate dysplasia and above with excision. It's philosophical in some ways, but clearly you have to provide a representative sample and act accordingly as to what the answer is going to be from the pathologist.
And I'd just point out that Dr. Sciubba in his presentation said PVL is a clinical diagnosis. So what I will get back from the pathologist is, suspect PVL might be possible, but clinically it's me looking in the mouth, seeing multiple locations, seeing where this is, seeing what it looks like. So the pathologist is not going to say, I see proliferative verrucous leukoplakia. They're going to say, you may want to consider this as part of the diagnosis because it's a clinical diagnosis that's being made. Is that fair?
Yes. Very good. Thanks so much.
Yes.
Hello. Hello, my name is Kevin. I'm a second-year dental student. I have a question, general question for the speakers regarding when I think of the profession of dentistry as a whole and new techniques, new knowledge, new technologies that become available, and as it sort of becomes clinically accepted as an advancement in the way that we provide care to patients, sometimes the change takes a long, long time. I don't know, maybe take implants, for instance, that have been around for 30 years, and before they become clinically everywhere, we're still getting there. I'm wondering if the developments, so this is a question for you guys as researchers, are you frustrated ever at how fast the knowledge gets put into practice? And also for the clinicians, are there things that you think, boy, I really wish I could put into practice, but I can't yet? And in general, for all of you, is the specialists who provide care to oral cancer, do the new advancements get implemented a lot faster than, say, things in general dentistry? Thanks.
Well, I think we would say sometimes, many of us would say, yeah, we're a little impatient. We'd like to see things move quickly, but we also know that we have to be cautious about what we do. So there's a balance between moving quickly and being cautious, because at the end of the day, whatever you want to implement in the clinic, whatever translational research or discoveries you've made, you want to begin clinical trials, you want to make sure that you've got sufficient information to begin a reasonable analysis to be able to move it into the clinic. There are protections that we have to think about, and there are certain moral obligations we have to our patients. So we have to balance that with our aggressiveness and say, look, I want to do this, put this in a clinical trial now. So it's a balancing act, but you have to do it. There are ethical reasons why we are careful about making these things. There are many instances where people have gone too quickly, and unfortunately patients have died. I'm not sure, what we learned about that is you don't move too quickly with certain things. You've got to learn to be patient. So that's the other part. And I think it spans not only the investigator, but the FDA and a lot of other agencies that really they're involved in doing this.
I think even with clinical trials having been successful for an agent or a drug to have passed the FDA hoops and hurdles, I heard it once said that you have to have at least 100,000 prescriptions written to determine whether or not this drug will be effective and or safe. Look at the drug Avastin, which had great promise some years ago when it first became available. And we know at the moment now that Avastin is being seriously considered to be taken off the market because of side effects, although the theory behind it, as Dr. Polverini will tell you, is right on target.
It's an example. Avastin does work really well in treating patients with macular degeneration. It's locally injected into the eye, into the diseased eye, and it works. So depending upon when you use it, how you use it, it can be effective.
And I'll just make a comment more philosophical. As one who's in the lab doing research, but also in the operating room doing clinical, when I first stepped into a lab, it was very difficult for me because I was used to going into an operating room and 5 to 15 hours later walking out and I had my results and things were great. And in the lab, that was not exactly the speed and has never been. And it took me a significant amount of time personally to begin to enjoy the intellectual stimulation and the joys that come from research and being in the lab. And so the only thing I would say to the young students who are thinking, should I spend a summer in the lab, et cetera, make sure you give that time and recognize a difference in how that feedback comes and how fast is research. How do we advance that? And there's small steps at a time.
Dr. Hellman.
Yeah, I wanted, this is a comment and a question. Since resveratrol
Good, because I was
is
getting flashbacks of residency, and I thought you were pimping me again.
I'm going to.
And I will do what I did back then. I will go home, find 3 papers, and we'll talk tomorrow.
Since resveratrol is such a strong antioxidant, shouldn't we use red wine to prevent oral cancer?
Or grape juice, perhaps, without the alcohol.
Oh, that came from Jim, not from me.
It has 100 times less resveratrol than wine.
Yes, please.
Hi, my name is Alex Forrest. I'm a D1 student, and my question for Dr. Ward is why has free tissue flap surgery been such a recent development in the reconstruction aesthetic and functional for patients? And what were some of the developments and advances that made this, this procedure a surgical option?
Great, that's a really good question. It is a more recent development in our department and in oral and maxillofacial surgery in general than it is a recent development. So our colleagues in otolaryngology, plastic surgery, have been doing free tissue transfer for much longer than we have. I think that for us, it became something we felt we truly needed to explore, and as we did that, rapidly we began to see the benefits of it. The downside, you remember the sleepy surgeon? That's real. When Dr. Hellman performed the first free tissue transfer in the state of Michigan, Dr. Hellman did the head, Dr. Hellman did the leg, Dr. Hellman put the head back together, Dr. Hellman was putting the leg back together. I hope I won't embarrass you, Yossi. I think it was a 16 to 18-hour operation, if I remember. And Yossi Hellman worked both sides and did both sides. When I came here in 2003, all of a sudden there was the possibility of having 2 faculty surgeons who could divide the case up. And I think for us, that became a critical factor in making what we have today. I mentioned Dr. Edwards. I mean, the fact that Dr. Edwards, with everything else he's doing, is willing on most of my cases to be there and be the reconstructive surgeon, that allows us to do this operation and still leave the hospital prior to midnight. And so I think for us, the evolution has been that we now have the manpower to sustain a clinical activity such as this, and have seen the benefits of it that we can now apply to our patients.
One anecdotal point that I could bring up is when I attend, every Wednesday morning, we have our head and neck tumor board, or patient care conference, as it's called, at the Greater Baltimore Medical Center and at Johns Hopkins. And I will tell you that 10 years ago, we might have had 1 reconstructive surgeon there, 1 plastic surgeon, whatever. Now they fight to get in because there are 4 or 5 of these young people recently trained at various places who now can do these things, whereas 10 years ago, they just weren't there. So to amplify your point, the population of practitioners willing and able and well-trained to do this has increased exponentially.
Yeah, so we have 3 full-time faculty who can all be at any end, that can be at the head or can be at the leg or can be at the arm. And so 3 of us can rotate around and do these things. And our residents have also become very proficient. So it is not very often that one of us is under the microscope with another faculty any longer. The residents are gaining proficiency because our case numbers are growing in ways that allow them to gain proficiency. So the number of bodies we have available to accomplish these tasks has dramatically grown over recent years, which has made this possible.
Thank you.
Yes, here.
My questions are fairly elementary. I'm a fairly new clinician in hygiene. And to piggyback on the brave D1, I want to ask again, in looking to be the first sign of detection, to be the first detector for a patient, is there anywhere I can go to see images of early detection? I see so many images that are dramatic, but I don't know just yet. I feel like I'm being extremely careful in my examinations and thorough, but I'd like to know more about that. And the second question I have is about the HPV, whether or not we see that as a screening tool in dental offices at some point. Do you think we'll be categorizing patients by whether or not they have the HPV or HP virus? And should we look at them differently, as a clinician?
As far as a place to obtain early images of early epithelial mucosal alterations, there are many places you can go. Go to Google. Best source anywhere for this level of information. Go to the Oral CDX website. Go to the American Academy of Oral and Maxillofacial Pathology website. There are lots of image banks everywhere. Go to your faculty right here. I am sure that Dr. Ward and colleagues here have loads of images of early erythroplasia, minimal leukoplakias. It's out there. It's everywhere. I've got hundreds and hundreds of images as one person. But right here in this room, I am guaranteeing you that you could get what you need.
And I think we could make a commitment to you between hundreds and hundreds of images and a little energy. We could put together something for the school that would be a database with some of those images. Sure. Yeah, I think that's an outstanding idea. The only other comment I have, you know how the dentist got all the credit for the early diagnosis? I really think the hygienist probably identified it and the dentist got the credit. So.
There was a question about HPV and using HPV for screening. Any thoughts about that from her?
I think we're probably not at that point right now. And the HPV diagnoses are being made based on biopsy of tumor specimens. That's what's really guiding treatment. So you probably wouldn't submit someone to a biopsy to find that out at present. And I don't know that we're far enough ahead in serologic markers that would make that really feasible.
To cut that off at an earlier point, I think when our health questionnaires are being redesigned into the future, we'll ask the difficult questions about habits. And that may at least begin to ask a question or two, and maybe look more perceptively and more probing, if you will, into those behaviors that are risky.
Hi, my name is Siraj, and I'm a second year here. I just had a question about the developing pharmaceutical approach to the treatment of oral cancer. Who do you think will be in charge of that type of care, and do you think the field of dentistry would be involved, in what kind of manner?
I certainly hope so. I mean, there's no reason why dentists can't do it. I mean, as the education of a dentist evolves, and there's going to be a greater expectation to really understand some of the biology that you're going to be treating. I mean, you're going to be taking things off the shelf, and you do right now to help repair bone. You'll get off-the-shelf PDGF, platelet-derived growth factor. It's really important to understand how that stuff works before you start placing it in someone's mouth. The same thing, as you understand more sophisticated knowledge of the biology, and you're going to be getting that as a student now, sure, you'll be able to prescribe those medications. Why not? If you understand how they work and you're willing to take the responsibility to monitor those patients, you should be able to do it.
A point that I make with many of my referring doctors, and I'll give you a real-life scenario. Dr. Sciubba, I've got a patient here who I think has erosive lichen planus. You treat that, don't you? Oh, yeah, I do. Do you have a lot of experience? Yes, I've got maybe 1,500, 2,000 patients that I've seen with erosive lichen planus. Well, how do you treat it? Well, I do this, that, and anything. Well, what sort of prescription do you use? Well, this is what I use. How often do you use it? And I basically say, if you have to ask those questions, you shouldn't be prescribing. Dr. Polverini's question is right on target. When we get to understand the process better and how to prescribe and how to manage those drugs and know the potential interactions, side effects, and downside effects, then by all means. Right now, the medical oncologist has that as their domain, but I don't think it's necessarily into the future always going to be theirs.
Do you think dental students today are going to be prepared to do those kind of things?
I hope so.
Yeah,
but I'm not a dean, you see. So
That's his job. I think that if we're not a part of the solution, it'll be our fault, not theirs. Because I'm successful as an oral and maxillofacial surgeon doing head and neck cancer surgery because I get referrals from dentists and from oral and maxillofacial surgeons. Do I get some referrals from the primary care side? I do. But the vast majority of these patients are coming through dentistry. So if ultimately someone else is managing them, it's because we don't come up to the table in a way that allows us to be competent to do it. And so our job is to come to the table competent to be able to manage whatever it is that will be offered to those patients in the future.
Very good. Over there.
Hi, I'm Lindsay. I'm a D2. Good afternoon, by the way, gentlemen. Thanks for coming in. I have kind of a patient care-oriented question for you. we just saw some really impressive pictures about HPV, possibly related cancers and that. But I'm already obviously very new to handling patients, and I've already experienced a few people who really just don't buy in to anything, like especially Gardasil. I think there are a lot of people out there who are really nervous about getting vaccines of any kind, and I just don't know how to reach those people. And I think, if you guys probably have a lot of experience with that kind of thing, I really just don't know what to say to people sometimes when they're resistant to some of our treatments, because in some cases they obviously have a point, but how do you make that step with someone like, hey, this is a good thing to think about?
Well, there are the Luddites out there. No matter what you do and what you say, they're going to remain Luddites. However, your position, I think, has to be one of consistency, one of competence, and continuing to go back at the patients with good information based upon your knowledge and your continuing growing knowledge base. So you do the best you can, but you can't satisfy all the people all the time.
Okay.
There's no magic bullet.
Here.
My name is Mikhail Garibov. I'm a first-year student here in dental school. First of all, thank you for a great presentation. It was really nice to see the modern research and modern both scientific and surgical research. So my question is a general question. It relates more to the public policy. The two most important things that I got from the presentation is, first of all, we haven't had much progress in survival rate of cancer patients, and second of all, early detection is very important. Do you know of any public policies that were implemented since the 1970s to help dentists detect early oral cancer? And if you do know of those, are those useful, or do you think there should be other ones developed?
Well, part of public policy is reflected on a package of cigarettes. Just look at the package. It deals not only with lung cancer or larynx cancer, it deals with cancer. So there's public policy number one. Smoking causes cancer, public policy demonstrated. It will go well beyond that, of course, but we have to buy into the fact that there are lots of opinions out there, some of which are ill-founded or not scientifically based, that continue to muddy the waters. I think we still have to be consistent, but we're well on our way. I think the Europeans are a bit ahead of us in terms of public policies relative to our own societal behaviors and nuances.
The only thing I'd add to that, the ADA did do a large campaign in 2003, if I'm remembering correctly, 2003, to try and increase the awareness for oral cancer in the dental, dental population. And so I think there are efforts that have been made. The studies that looked at the effects of those efforts, we still have a long ways to go, but they were making those efforts, and I think those are to be applauded.
One last thing about public policy. Remember, public policy is driven by lawmakers. Lawmakers are assailed daily by lobbyists, and one of the biggest lobbying groups is what? Tobacco industry and the alcohol industry. So they have to overcome an awful lot to make those courageous decisions to influence public policy at a legislative level.
So we are going to have one more question, and then we're going to have a reception right after these last questions. So if you have more questions to make, I'm sure that the speakers will be glad to talk with you at the reception. So let's do the
before you
last
ask, I just tell us where you're from, because at the moment it's D1's 5, D2's 1, D3's and D4's 0, and dental hygiene 1. So.
Okay. I am a 12-year practicing dental hygienist.
There you go. All right.
So I've been doing
the private
this for a while.
practitioners are now represented.
My question is, I know that over the years, my exam has changed, and I currently wear scopes. I try to make sure that I do the best oral exam that I can. However, I know there are some new products on the market. Any opinions, comments, or recommendations that may help an office?
May I ask you a question?
And I'm not from the north, no. You can ask, if that's your question, I am not a northerner, no.
No, I was just wondering, have you diagnosed, so my one every 15 years, have you diagnosed an oral cancer through your office at present?
Not at this office. I have come from I have practiced in Ohio also. Boo, I know, sorry. But I'm not from Ohio either, so you can't fault me for that. But I've sent several out for biopsy. I was
Good
told,
for you.
I was told by one dentist that we did get a positive, and the person did have surgery removed off the tongue, so that was yes.
Good for you. Congratulations.
The only other diagnosis I've had is a tumor in the jaw for an 18-year-old. He also had to have surgery, part of his jaw removed, but yes for catching that too. But so those were my only two experiences.
Great. So the numbers are playing out.
So the question basically is, what about these new modalities that over the past several years have been brought to market, and how effective are they in defining things, I suppose? I just read a paper about some of the light technologies, in particular the Velscope. It is not able to distinguish lower risk from higher risk lesions from this particular study. However, there are more advanced spectroscopic techniques, microscopic spectroscopic techniques, which in fact are far more accurate, but are not ready for prime time yet. So I would think that within the next 5 years or so, we're going to see much more easily available, much more highly accurate technologies there to help us answer those questions. But we're not there yet, either with the Visilight, which I think is not terribly good. I think the Velscope is probably better, but not ready for prime time either. And give it another few years, and you'll see some very interesting stuff coming up.
You know, there's a whole emerging field of biomarkers and diagnostics, and certainly salivary gland diagnostics is an emerging area where there's great promise. I think in the end, what we need to see is a yes, no, not somewhere in between. We're somewhere in between now, and eventually, as we become more precise and once again understand mechanism in which of these things is really important, we will eventually get a day where a patient will come in, they'll lick a piece of paper, you'll put it in something, and it'll tell you that this is up at this point, that means this patient's at risk, or this is down, this patient's not. And we will see that in your lifetime for sure.
Remember, mammograms are done every day in this world, in this country, everywhere, and 80% of them really define benign disease. So keep that in mind as well. Yet it remains the standard in terms of a screening technique.
And my only comment, so I agree, not quite yet. My comment to the students is I hope 15 years from now you can stand up and say, I screen all of my patients very carefully. If you are doing that, then I absolutely applaud you.
So along those lines, I would like to just give an opportunity to each one of you to give a final thought to all of us.
My final thought is keep looking. I think we overuse the term oral cancer screening. I think we simply have to do a good, solid mucosal and oral and head and neck examination. The best tools you still have are a good light and good eyes.
I feel very fortunate to be part of a university and part of a school that has the deep, rich talent that we have. And not only on this stage, but also in the audience. The individuals, I think, who are going to, so I look, future is bright, not only in terms of we're going to have some of the best educated practitioners, but we're going to have faculty that are continually going to be asking the tough questions and doing the hard work that's going to make our job in the future much easier.
My comment, and no disrespect at all to the last questioner, a number of years ago when I came to the University of Michigan, I was planning to go back to Southern California and be in a private practice. I would be doing very different things than what I do today if that vision had become my vision of my personal life. I'm grateful to be associated with an academic institution, incredibly grateful to be associated with the University of Michigan, and I appreciate the opportunity I have to interact with you as students on a day-to-day basis. Think about your careers, think about what you want to do, think about the differences that you can make in patients' lives, and consider the impact of your career. Because at least when I was at your stage, I had no idea the things that I would be doing to make a difference in patients' lives that are now available to me today.
Let's recognize this wonderful time with a very strong round of applause.
Very fun.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.